Hello, welcome to Podsongs. I'm Jack Stafford, and I interview inspiring people in service to others as inspiration for a new song. Today, I'm speaking with an American epidemiologist and professor in the Department of Epidemiology at Harvard T.H School of Public Health. He's also the director of the Center for Communicable Disease Dynamics, and he's currently working on modeling the transmission of coronavirus. Coronavirus again. It's still here. Got to do another song on it. Anyway, in my research, I heard him talking about something called the streetlight analogy. This is apparently a big thing in science research because there's the tendency to research easy areas, particular questions, cases, and variables for reasons of convenience or data availability. It's based on a joke. Now, I'm not very good at telling jokes, but I'll give it a go. So there's this drunk guy looking for his keys, and he's looking under this lamppost, and this policeman comes along, says, "You need some help?" So, "Yes, please," and he helps him. But after about half an hour, they haven't found his keys yet, and the policeman asks him, "Are you sure you lost the keys there?" And he says, "No, I lost them in the park." "Well, why are you looking under the lamppost?" "Well, this is where the light is." So one of these streetlight research areas is gain-of-function research in viruses. This is where you take a deadly virus and make it even more dangerous by giving it more functions. So you'd be prepared to fight it if it happened to mutate in that particular way. Which sounds a bit crazy to me, but also to my guest because he campaigned against it for a while and he got it stopped. Let's learn from Marc Lipsitch. Well, thanks for taking the time to speak to me. Before I ask you a ton of questions, or I'm sure you've been asked many times before, is there something you'd like to talk about? And more importantly, is it something I can write a song about? Something you feel needs to be addressed or drawing attention to?
Wow, that's not. Let me think. Nothing jumps out at me at the moment. I haven't given a lot of thought about the role of songs in COVID, so I'll be guided by you.
Oh, well, I guess the last year, has it been a blur or?
Total blur, yeah. Total sense of time is gone, and memories from before are fast being erased, and yeah, it's very strange.
I guess if you're an oceanologist and you're studying tidal waves and your whole life you're waiting for one to come, you're fully prepared. But once you see that wall of water, yeah.
Right. Yeah. Well, studying them and being in one are very different. And certainly, I think all of us in my world had imagined what it would be like, but the particularities are, of course, the small things that you don't think to imagine, like the smell of the mask and the on the small scale, and the sort of shocking abdication of responsibility at the national level on the large scale. Both of them kind of, those are two surprises on very different types of scales.
Because you're an expert in modeling, just to give some background, and you've been pretty accurate with the models for how COVID would spread, no?
Yeah, I mean, I think that there are different levels of accuracy. I think I got the big picture right very early. And then I think everyone is struggling to get a lot of the details right, because there are so many moving pieces, and it's as much about predicting human behavior, which we aren't trained in mostly as epidemiologists, as it is about predicting viruses.
And also government behavior with the lockdowns, intermittent.
Yeah, and government behavior and We can predict how evolution will progress once something new appears, but we can't predict what will appear. So with the new variants, that something might show up was predictable and roughly how it might behave. But of all the possibilities, no one knew which types of escape or more fit variants there might be.
So how does the process work then? So you hear about the virus back in whenever it was, and then you study which age groups it hits and how it's spread. What you need these inputs to your model, and then you can exponentiate.
Yeah, I mean there are different stages. So initially, the major question was, is it transmitting efficiently in people through casual activities, and is it in many different places? Because if it's in many different places, then the weak link problem happens, and even if Singapore and Taiwan and eventually China all contain it, once it's spread around the world, it's the worst. the weakest link becomes the dominant force, and there were a lot of weak links. There were a lot of weak links. So that's the first sort of layer of trying to gain a sense of whether this is a localized problem or a potentially global one. And then as you're refining models, you then try to put in those details like the ones you described of who gets infected, how the contacts are working, how contacts are changing because of the fear of the virus and because of government measures, how vaccines might work, who might take vaccines, and all of those kinds of questions.
So I guess the modeling is one thing, but then how do you find it difficult to get it down into simplistic terms so that even a president can understand it?
Well, there are presidents and presidents. I think what's hardest is to communicate that models are if-then statements. They're very rarely predictions about epidemics. For the weather, you can make predictions, not very long term, but for the weather, we understand the physics reasonably well. We have tons and tons of data, and the system is in many ways very similar to what it was 100 years ago, although it's warmer, and you have to account for that. In human behavior, in epidemics, you have human behavior which is not well understood, which doesn't have physical laws. You have a new virus with surprising properties and continuing surprises, and you have decisions of politicians that are also hard to predict and that are influenced by the model outputs. So, everybody wants to know, when will it peak? And that's not a well-formed question. The question is it's very hard, but in principle possible to answer the question, when might it peak, if we take the following steps. But that's not what people want. And I think sometimes this is maybe less true now, but in the summer, people were asking those questions a lot. And I found myself saying, asking for that is not only scientifically asking for the impossible, but it also removes the sense of agency, right? This is in our control to some degree. It will spread faster if we don't take control measures. It will spread more slowly if we do take control measures. And asking for a forecast is sort of implying that it's not something that we can fix or try to fix.
So isn't that infinitely complex, though? You have to make a model that accounts for the outputs of its own modeling, of its own results, if they get implemented.
Right. If you were going to try to have an unconditional model that said not just if we do X, what will happen, but what will happen full stop, then you would indeed have to account for the predictions of the model and the feedbacks to behavior.
So you have sophisticated AIs for this, or it's you on a blackboard?
I don't think it's possible at this point to do those feedbacks. But in fact, some of my colleagues are more into the prediction, the detailed prediction efforts by far than I am. I've actually decided that that's not the best use of what I'm good at, and that I can actually do more good by trying to understand the data better and trying to design studies and do other kinds of activities related to understanding the pandemic, and leave the detailed predictions to others, which I think largely hasn't been possible, but I'm glad that I'm not joining that group.
Because you were focusing on modeling like when schools can reopen and who gets the vaccine first.
More of the second, more the question of who gets the vaccine first, and then trying to work with colleagues to figure out ways to answer the unknowns about the vaccine's effects, how much it affects transmission and how much it affects severe disease, and some of the really important questions that are not there in the original trials.
And these variants, are they affecting things?
They seem to be. The B.1.1.7 variant in the UK and elsewhere is certainly making control much harder because it's more contagious, maybe a little bit more lethal as well. The South African variant, I actually can't remember their names. I have to read them up the screen. The South African variant and the Brazilian variant both seem to be capable of infecting or of escaping immunity to a degree that's currently unknown. But that seems so far as if it's possibly substantial, especially the Brazilian variant. So the good news so far seems to be that the vaccines that have been tested in South Africa still seem to have high effectiveness against severe disease and hospitalization, though they're not as good necessarily against in just preventing the infection or the disease altogether.
Do you know if you can be vaccinated but still be a carrier and take the virus to other people?
So that's a question about whether it affects transmission and infection. There's a tiny bit of evidence that is encouraging from the Moderna vaccine and a little bit more, but not much, from the AstraZeneca vaccine. And otherwise, we're really pretty much flying blind. I think those data will start to come out from other studies, but the way the trials were designed was to get a quick and accurate answer, and that was with symptomatic disease. So the impact on transmission is going to require further studies.
And natural immunity after people who've had the virus, is that different?
Different from?
In terms of transmission.
So again, it hasn't been carefully studied. From other coronaviruses, the data from the past suggests that natural infection reduces your risk of disease and the amount of virus you shed if you get infected, and it also reduces your chance of getting infected. So it's sort of partially beneficial on each of those axes, and that adds up. So I mean, altogether, that's a lot, but it's not perfect.
Yeah, how do you know if your data is reliable? Because you're getting all this information from around the world, even with deaths, for example. I heard you say that they're underreported, but in the UK, for example, it says underneath the results, it says within 20 days of a positive COVID test result. So that can include people who died of other causes.
Mm, yeah, I think I'd have to see the way the UK does it. I don't fully understand, but um, uh, yeah, I think in trials there's a of vaccines there's more specific effort to adjudicate whether a death is due to the infection or due to something else. Um, but the overall deaths are complicated in many ways. They get overcounted sometimes because of counting just anybody within a diagnosis period, but also probably more importantly undercounted for two reasons. One is for a long time there wasn't enough testing. It's gotten better, but there wasn't even enough testing to test all the potential deaths, and also that the sort of damage, what's the word, collateral damage from the not having adequate healthcare resources also leads to extra deaths from heart attacks and untreated cancers and other illnesses, and that is also a consequence of COVID, but it's not measured as a COVID death.
So say that again. You're saying that the measures taken against COVID can increase the deaths as well.
Well, not so much the measures taken against COVID, but the unavailability of healthcare because people are delaying so-called elective healthcare, and most healthcare is elective up to a point, but actually is prolonging your life, and so to some degree, missing that is going to add up in the population, and then acutely, if someone can't get an ambulance because the health system is overwhelmed and they have a heart attack unrelated to COVID, some of those people die who wouldn't have died otherwise.
Right, so those are collateral deaths from the healthcare system being overloaded.
Yeah.
Okay. Did I read that every year there's less hospital beds because of the way the health system runs, and is that the case in America? There's even building some hospitals without beds because it's more efficient to treat outpatients.
I don't know the numbers, but I think certainly. Yeah, I won't comment. I don't know that.
Okay. Yeah. So before, because obviously you're an expert in epidemiology and the modeling. So, and you make these models as plans to help people prepare. So what is the pandemic protocol for a virus for an epidemic in general? Is it?
Well, there was an effort around the world as people were worried about bird flu and about other pandemic threats to develop plans. And those plans more or less include the sorts of measures that we've taken in response to this pandemic, in terms of use of masks, in terms of use of social distancing, in terms of closure of non-essential businesses and the like. I think we had a somewhat naive sense in some of those plans that we would understand the gravity or lack of gravity of a situation, and then we would sort of titrate our responses. And instead, in 2009, we were very concerned that it was a very bad flu pandemic, and it turned out not to be. And we began to realize that when the hospitals didn't get overloaded, mainly, and the death toll was smaller than feared. And so we were able to ratchet back down pretty quickly. But we reacted strongly in 2009 with many of these same measures. In COVID-19, in the US in particular, but actually many places, there was a slowness to respond because it was somehow seen as it's China's problem or it's Italy's problem. And even Italy didn't realize how big a problem it was until they were in crisis. And with this infection, as many others, when you reach crisis, you already have a lot of extra cases. You already have a lot of cases, and you don't get immediate results when you crack down, because those cases have to go through the system, and it takes 2 or 3 or 4 weeks before someone infected today becomes a intensive care patient. And so you have a delay in the response to your interventions. And I think there was not enough focus in the planning on sort of taking the real-time perspective and on how you have to act based on what you know rather than based on full knowledge.
I heard you bemoaning the results, the response in America.
Yeah, we were very slow. But I was talking with a friend about the sort of, if you look at the world in very, very crude terms, there are places with 1,000 or less deaths, and there are places with tens to hundreds of thousands of deaths. And it seems like a strong separation.
Why is that?
Well, so that's the interesting question. I mean, it's clear that the quality and timing of the response mattered, but a sort of well-run technocratic country like Germany did a little bit worse than a deliberately badly run country like the United States. I mean, that was by the
UK
or the UK.
Boris Johnson was out shaking hands with everyone in the street for weeks before he got the virus.
Right. So the UK was doing it. The US, by the admission of the president, was trying to minimize and pretend it wasn't going to be a problem. And Germany, was trying to be responsible. And their results are better than ours, but they're not that much better. And I think my current hypothesis, and I think this is going to be the most interesting question that future people will try to unravel, but my current thinking is that places that were able to crack down very, very hard, very, very early in their own epidemic, which might have not been at the very beginning because it took a while to take off in places like Australia. But the places were able to really, really crack down before it got out of control had one outcome, and the places that really, really cracked down almost as hard, but after it was much larger, had another outcome. But I will need to find that view and see if it holds up to scrutiny.
Like South Korea and New Zealand and
yeah.
But that's always the way, isn't it? The faster you react, surely that's number one.
Yeah, it does seem that way, but it's there seems to be an element of luck in the timing of when you had to react in order to be timely. So I think a few places. Well, I don't know. I just think it's a strange outcome that that well-run Western European countries basically have only done a little better than badly run.
If you don't know, I mean, what hope is there for the rest of us?
Well, that's a problem for the future.
I'm in Italy, and so we got locked down quite early, and I'm in the south, and in the north it really hit hard. It was all in the care homes and the old people, and I think it's mostly. I think only 2% of the people who died were under 60 or something like that. So it's a very age-oriented disease, isn't it? Is that still the case?
Yeah, it still is much, much worse if you're older, and goes up exponentially with age by many factors of 10.
Does that affect, can the schools be open then? Are you in favor of open schools or universities? Or?
Well, I think schools, opening schools is super important societally, especially for people who are already disadvantaged, but really for everyone. And it's really important for getting the rest of the economy back on its feet, both in the short term so that parents can work, and in the long term so that children haven't lost a whole year of education or more. I think the risks that we have to mitigate from that are the risks mainly to adults. So those would be the people working in the schools, the teachers, the cleaners, the food service staff, and to the families of the kids, but especially the people working in the schools, because younger kids probably are not major transmitters and are mostly getting it from adults rather than giving it to adults.
Some of the schools are open here, but they have the windows wide open, so the kids all have to wear their jackets in school. Yeah.
So I think everything that can be done to make opening schools safe should be done, because it's such a valuable activity, even more valuable than almost all the other activities that people are trying to do. But I think in some places, the conditions of the school buildings are such that it's too cold outside to open the windows, and it's too poorly ventilated inside to safely reopen. So I think, especially for older kids and for places with poorly constructed buildings, it's going to be a while.
But you wouldn't vaccinate children?
I think we should try to vaccinate as many people as we can once there's data. I mean, we need data in children before vaccines can be authorized. But it wouldn't be my first step. My first step would be to vaccinate the adults that work in schools as a way of. My first step towards getting schools open would be to vaccinate people who work in schools.
And these home testing kits, I spoke to Dr. Eric Toppel, and he said that the kits were ready. They were home testing kits ready in April last year, and there's about 21 available on the market, but they're not mass produced and they're not widely available. But they can cost as low as $1. Is that's one of the biggest failings, you would think? Or?
I think that we really need to scale up the use of cheap antigen tests like the ones you're describing. There's been a lot of resistance to them, I think mainly because they don't detect low levels of virus that would be important if you were trying to make a decision about how to treat someone, but are not nearly so important if you are trying to detect who's contagious. So the evidence is pretty strong that the better antigen tests are accurate at diagnosing contagiousness, and they're not accurate at diagnosing 3-week-old infections that are no longer contagious. But that's actually a strength. And I think it's been really hard to get through to people's minds the distinction between a test for contagiousness or for your risk to others and a test that you would use if you were trying to make a medical decision for the patient. So I think that's been that has been a failing, the failure to get those tests out and used. And that means that there's not much demand, and that means there's not much supply, because it's not in anyone's interest to make something that's not licensed and not used.
Another failing, yeah. I mean, so what can you suggest for the future to avoid these failings? You'd be more involved in policy, or take it out, have a better organizational structure at the top to take the decisions, or should it be left to the president and things like that? Or?
I think there are a lot of layers. I think without leadership, strong and science following or science aware leadership at the top, we're going to repeat all the failings, no matter how good our technology is. And I think that's been very clear that the least science following countries, unfortunately, including mine and the UK, are not doing well. If we had strong leadership and committed leadership, I think there are a bunch of things. One is to really dedicate resources to dealing with the economic impact of control measures. Control measures have to happen, but you have to make it humane for people to comply with those control measures, not only because that's the right thing to do, but also because, for example, if you don't pay people to stay home when they're sick, then people don't stay home when they're sick and they transmit more. So the measures get defeated by economic reality if you don't account for that. And that's just basic economics. And in the US, that's harder because most states can't make those decisions. States have to balance their budgets, but the federal government doesn't. So in the past, when the federal government wasn't interested, that was a special problem in the US. In terms of technology and systems, we very desperately need better information systems to aggregate medical information in such a way that people can have an understanding of what's going on. Electronic health records were supposed to do that, and they're really good at billing, but they are not really good at producing.
I've heard this one as well, yeah.
And the UK is an example of a place that does that better, because there's at least the NHS and the Office of National Statistics, which together have really been able to build a picture of what's going on that's much more detailed than most other places. Israel's another example where there are 4 HMOs, everybody's in one of them. The Ministry of Health has all of their information, and so they know who they've vaccinated. They've been able to do it very quickly, and they're benefiting from that. So information systems matter. There were many reasons not to tolerate or allow the levels of inequality in general, and especially in health, that we had before, quite apart from pandemics, but this is another one. And the death toll and the toll in the hospitals is largely and disproportionately due to people who are otherwise disadvantaged, either economically or racially or both. And these kinds of disparities are bad in peacetime or outside of pandemics, and they're bad for everyone quite directly in the middle of a pandemic. And then I think the last thing to say is more positively, we as a scientific community learned a lesson from Ebola, that we should not be caught flat-footed during epidemics with vaccines, and we should instead develop vaccines in anticipation. They might not be exactly the right vaccine for the next one, but at least they will get us prepared. And that bet really paid off. The rapid pace of vaccine rollout or development in at least the rich countries has been a direct consequence of those investments that were made just over the last half decade, 5 years. We haven't done the same thing with diagnostics. We haven't done the same thing with treatments to a large degree. And so having a sort of concerted global effort on diagnostics and treatments, I think would be one of the clear lessons of this pandemic. And then the last thing, I'll shut up, is I have a long list.
You've thought about this, I'm sure.
Last thing is we need much better awareness of what's going on in the viral world. And that means sequencing of the capacity to sequence the infectious material from any patient quickly and accurately, and then process the data in such a way that we can understand it. And again, the UK has been a real leader in that. South Africa has been a real leader in that. The US has been a real laggard. And most other places are not even in the league. So we need to follow those. We need to beef that system up for whatever pathogen comes next.
Well, that brings me into my next question, because when I was researching you, I heard you talking about preparedness and aspects of viral research. And in 2015, you were talking about something called gainer research in select agents. Because gain of function. Could you give me a bit more information about that?
Sure. In the first half of the last decade, there were a number of studies that were funded by government funds and some foundation funds to enhance the contagiousness of already lethal viruses, particularly flu viruses. And as we began to learn more, it turned out that work, in some forms, had been going on for about a decade. And the concern that some others had raised, which I agree with, is that there was a chance that these kinds of experiments, when published, could inform bad actors about how to cause a bioterrorist event.
Publishing the recipes.
Essentially so, yeah. And that's the notion of dual use that has been raised. And that I think is a concern. But there's another concern, which is the one that I really focused on during that period, which is to what extent would we be afraid of laboratory accidents happening with these enhanced pathogens? And we usually think of laboratory accidents as things that we want to prevent because we want to save the lives and the well-being of the people working in the labs. But most research on dangerous pathogens doesn't consist of trying to make the pathogens more contagious. So when you're doing that kind of a study, then the risk is not just to the lab workers, but to the global population if the virus continues to spread. So I was one of the many voices, but one of the loud voices that was saying we should have very strict review processes for those kinds of studies and really force the people doing them to justify why that risk is worth taking. It is one of the possible ideas about where this virus came from, that it may have come out of a laboratory, not necessarily from someone trying to enhance it, but maybe from a natural isolate that was isolated and put in a laboratory, or from enhancement experiments. Those are among the hypotheses that are being investigated right now. I think it'll be hard ever to say for sure what happened. I think the kind of crazy conspiracy theory that this was a deliberate biological release is a crazy conspiracy theory, and I don't advocate that. But I do think that the accident hypothesis has to be considered. It may not be right, but it has to be considered by the investigations. And then the final wrinkle on that is that there are now, for very good scientific reasons, people trying to understand how variants of this SARS-CoV-2 behave, and that involves constructing variants that might be more transmissible or might be more virulent. And I'm supportive of doing that in certain laboratories because there's such a pressing public health need. It's not that you should never do this kind of work. There's a real need to understand these things. I am concerned, particularly again about safety, that with lots of people trying to do their part in this epidemic, including laboratories that may not be used to working with these kinds of variants, that we need to make sure that safety protocols are in place so that we don't add to the problem. But I think studies like this need to be done, but they shouldn't be done in just every laboratory.
Because these security breaches, they do happen even in high containment labs in America, no?
Yeah, I mean, it's not so much security breaches, it's really errors. It's just accidents. Somebody switches a vial and thinks that some virus is dead when it's not been properly killed. That's a common one, actually. A relatively common type of mistake. and nobody's trying to hurt anyone, and everyone's trying to follow the procedures, and everyone's got goodwill and all of that. It's just that humans are fallible. And to me, that's the part that I'm actually more worried about than the terrorist approach, especially with this virus, where we've got the problem already, and that's it's not an easy one to make that much worse.
And there's also, it's difficult to find out even if a leak. No, the laboratories are not publicizing it.
Right. I mean, I think there would be. Yeah, the lack of transparency has been a long-standing problem in terms of knowing when lab accidents happen.
So back in 2015, we're about this gain of function, trying to get flu viruses so you can get them to be more transmitted by air. Were you successful in stopping that research in America?
Together with a number of other people, we were successful in getting a moratorium in place on funding it temporarily. That moratorium has been lifted, and there are some somewhat better controls in place to review those kinds of studies. I think the momentum behind doing those studies for the sake of scientific curiosity was a little bit slowed down, and that's good. But it still is not a review process that I think is adequate. And different countries have different situations.
So when was the moratorium lifted?
Before COVID, which means that I don't remember. No, it was lifted in about I think it was lifted in the very beginning of 2017, right at the end of the Obama administration. And the sort of new regime was put in place about a year later. So this was not a Trump thing. This was started before Trump.
Because in my research also, I read in the USA Today, they were trying to debunk some truths, and they found that the National Institute of Allergy and Infectious Diseases gave a small grant for gain-of-function research to the Wuhan Institute of Virology, among other foreign laboratories, to continue this research outside America. Do you know if that rings a bell?
I have not looked into the Wuhan Institute and all of the origin issues. I am very anxious to find out what happened. It has not been my priority, both because I have other things that I'm focusing on right now related to help with the pandemic, and because I think we need scientists to be working together and not starting arguments in the scientific community unnecessarily. I mean, we should be having scientific discussions, but I think this is an argument that is really about the direction science should go, and I'm looking forward to the time when that is the most pressing thing to work on, but I don't think that's the case right now.
When the dust is settled, yeah.
Yeah.
Do you think there will be an inquiry?
Well, the World Health Organization has sent a team, and they have stated that all hypotheses are on the table. So I think we will find out.
Yeah. So you working in the background before this pandemic. Now you have over 200,000 Twitter followers and people wanting to write songs about you. So how is it for you and other epidemiologists being in the public eye like this?
I think we're all looking forward to being obscure again. But I mean, there are some positive aspects in an overwhelmingly horrible time. I think it's nice that people are becoming more aware of what epidemiology is and of some of its value and of a lot of the content. I mean, I no longer have to explain to class, I don't have to tell them what the R value is because they've all read about it, heard about it on YouTube. So that's something. I think that it's been a period of incredibly hard work by thousands of epidemiologists around the world and others, clinicians and researchers of other sorts. I think we're all just ready for for things to go down a bit. I think the scientific community has done a good job, not a perfect job, but that's to be expected. And I think one thing I am impressed by is how well scientists have stepped up, especially in the United States, where really the government didn't do its job in communicating. But there's been a real groundswell among thoughtful scientists of an effort to inform the public, describe what we know and what we're uncertain about and why that matters, and to sort of show the good part of the scientific process at work. I think people are sometimes surprised to see how much debate goes on in science. They think of it as building up facts, maybe, because that's how you're taught it in school. But a lot of it is figuring out what are the facts and what are the misinterpretations. And usually that's done in a way that nobody outside of science pays attention to. And so it's been interesting to be more in the public eye and have, each scientist is trying to improve their understanding. And it's not like we all form a view and then stick to it. But usually people aren't asking us, well, aren't you contradicting what you said last Tuesday? Because nobody knew what we said last Tuesday.
Yeah. If there were dinner parties, you'd be top of the list now.
Exactly. We would be, we should be contradicting what we said last Tuesday if we've learned new information that makes it wrong.
Yeah.
In a fast-moving epidemic, that's the case. I mean, every week, I think, views, for good reason, change.
Do you think some of the disagreement I had Martin Kulldorff on the show as well, about the Great Barrington Declaration. Do you think most of the disagreement has been between policy rather than the virus itself? Or?
Yeah, I mean, I think there are different kinds of disagreement. I think the Great Barrington Declaration and the response from the John Snow, which I signed, was essentially a policy disagreement. I don't think there was any. Well, I have a very strong view that there was no scientific basis for what the Great Barrington people recommended. They just were saying it would be great if we could do this, and they weren't asserting because there was no evidence that was actually possible. They were just saying, let's do it. And I would say that John Snow had more scientific content because it said what we know doesn't work so far, which is letting the virus go and protecting those people at high risk. That there just wasn't a way to do that until the vaccines came out. And now there is a way to do that. So that, I think, was a policy disagreement, and a disagreement about the use of science, but not about the topic, about the content, the scientific content, in a way. I think in the regular process of science, there's disagreement about how you interpret laboratory results. For example, the variants, what we know about the variants and vaccines is almost all laboratory data right now. There's a little bit of data now from human trials, but mostly it's laboratory data. That's different laboratories will find different things until their methods become uniform, and different people will interpret the likely consequences of those differently. And that's just normal science, and I think that's fine. And it's more freighted at a time when people are watching every statement from a scientist. Mm-hmm. But it's just what we do. We debate what the data tell us and what the next thing we need to know is and how we're going to find that out. And then we go about doing that. And that feels like just a very public version of the same thing we always do.
Okay, well, that's great. Well, this has been so informative. I mean, I can't think of any more questions. Obviously, well, yeah, I can think of hundreds more. I mean, there's loads of people who would be like to be speaking to you now, and it's on everyone's mind in the world. So, but is there something else you think I didn't cover?
I don't think so. We've ranged pretty widely.
Any ideas for the song, or are you still leaving that to me?
No clue. No clue.
Okay. Great.
All right.
Things have been really, really nice. Thanks, Mark.
Thank you. Bye-bye.
I was reading in the Lancet just the other day about the risk and benefits of gain of function. How some thought it desirous give functions to a virus from virulence and transmissibility, thereby enabling assessment to inform investment in preparedness plans for pandemics. But what was the cause of the funding pause? Human error in high containment labs. Gain of function, strange instructions, make assumptions. Gain of function. We can't even predict how influenza hits from one season to the next. Instead of understanding these and improving the vaccines, they look for answers where the look is good. Testing out the ifs and sequencing the what's, like how about if this virus was airborne? Cause if we know how transmission goes, we're better prepared to prevent it. Gain of function, strange instructions, make assumptions. Gain of function. From ferret to ferret, really is generic. Research it, regret it, disaster you'll inherit. From mammal to mammal, it's utterly disparate. Don't get it, don't sweat it, it'll kill you if you let it. Why are you looking under the street light? Do you think the answer's over there? The searcher answer with a spurious repose. No, but the light is brighter over here. Gain of function, strange instructions, make assumptions. Gain of function.
Thanks for tuning in. As always, please like, subscribe, share, do anything you can to help promote the show. If you want to hear the song again, you can go to Spotify, iTunes, Deezer, etc. Stream it there, or buy it for $1 on Podsongs.com. This will help support my musicians, Maurizio Sarnicola, Massimino Vozza, and my researcher, Dori Verba. Thanks for tuning in. See you next time.